So, management of spine trauma. I'm going to speak in brief about management of spine trauma. So, first, historical perspective. Okay. So, spinal cord injury has been described. The first recorded incident of spinal cord injury being described was in the Edwin Smith surgical papyrus, which is dated to around 2500 BCE. So, beginning in that time, it was believed that spine trauma could not be adequately treated. So, it's a hopeless case in that time. So, it is basically considered as an ailment that could not be treated. So, early responses were marked by therapeutic nihilism, so poor outcomes, minimal understanding. Advances in surgery, anesthesia, microbiology, and imaging, such as blisters, antiseptics, X-rays, all of these laid the groundwork for safer intervention. So, it was not until the beginning of the 20th century that people seriously considered spine injuries to be a treatable condition. So, these are some of the highlights during that. It's useful to note that the First and Second World Wars were pivotal points in which spine injury cases began to be considered treatable, because, as we all know, war causes a lot of spine injuries. So, during the post-war era, surgery became more acceptable as techniques for rehabilitation improved and surgical safety was further improved. So, at present, it is an ailment that can be treated. So, multidisciplinary care models developed by pioneers like Ronald Monroe, Ludwig Guttmann, George Breithaupt led to the foundation of spine injury units and rehabilitation systems throughout. Unfortunately, we do not have a rehabilitation system in our country. Maybe we can get working on that eventually. So, major progresses include spine stabilization techniques, initially with Harrington rods, halo traction, eventually leading to critical fixation, which has become the standard of care now. Neurosurgeon better management, infection prevention has become better, sexual administration, pain control, stress management has become more organized, and now we can do all of these things, and assistive technologies have also become more prevalent in this case. So, at present we can treat spinal cord injuries. So, a brief overview of the management principles. So, Dr. Muhammad has covered initial management. I'll talk in brief about the close reduction of cervical fractures, which is something that needs to be done when the patients present initially. So, cervical fractures with dislocation associated with spinal cord injuries have the highest morbidity and mortality, and they are amenable to early close reduction. So, the reduction, the easily distributed reduction, and also there is a better neurological outcome if we can manage to get it done as soon as possible. So, the current preferred technique is awake, tongue, or halo ring assisted reduction is preferred because we have improved control in the procedure, and we can also examine the patient during the procedure so that we do not cause a neurological damage during the procedure itself. So, awake with some sedation, traction is the preferred method. So, moving on to the medical care issues, critical care issues, the respiratory airway, spinal cord injury patients are at risk of hypoventilation. So, it is optimal to keep these patients at a saturation of above 92%. And patients with high cervical spinal cord injuries, we should not hesitate to do early tracheostomy. And recent evidence has suggested that tracheostomy within 4 days improves outcomes in these patients. Hemodynamic management is also an important component of this. Neurogenic shock is the distributive shock that occurs because of reduced sympathetic outflow that results from spinal cord injury, which leads to loss of sympathetic tone and underforced parasympathetic activity causing hypotension and bradycardia. So, the AO Spine and Praxis guidelines in 2024 recommend augmentation of MAP to 75 to 80 millimeters of mercury, but no higher than 90 or 95 for a duration of 3 to 7 days after the injury. So, blood pressure optimization is very important in spinal cord injuries, and the recommendations may be weak and low quality, but there is good evidence to support their use. So, corticosteroids, there was some controversy initially. I think the controversy has been resolved by now. Corticosteroids have not shown much clear benefit in spinal cord injuries, but they do worsen the risks of GI hemorrhage, respiratory infections. So, I think most recommended recommendations are to avoid corticosteroids in spinal cord injuries. So other management issues include the GI management, the risk of IBS and all of these things, and DVT prophylaxis, ulcer prophylaxis, and management of the various dysfunctions, which are very broad topics that I'm not going to go into detail. Surgical management, I'm going to discuss in brief about surgical management. I don't think we have enough time to cover all of that. Maybe we could talk hours about it. So let's be brief. So whether there is an indication to do surgical management or not. So we can use either the AO spine guidelines, which gives very clear definition on which cases require management based on the types, and which cases can be managed with just immobilization. One other method is the Dennis 3-column method. If there is failure of 2 or more columns, we consider the spine to be stable. And there are several scoring systems that are also available. I don't think one has been proven to be superior to the other, and clinical judgment is also an important factor in making the decision. The goal of surgery is to decompress the injured neurological segment, correction of any deformity, and the reduction of the fractures, and restoration of the stability is achieved by fixation using instruments, and the fusion is achieved by the use of bone grafts. So when should surgery be performed? According to the latest guidelines, early surgery is recommended, although the quality of the evidence is poor. But early surgery within 24 hours has been shown to improve outcomes in these patients. The utility of ultra early surgery is still under investigation, and I think the guidelines did not investigate this further because of the paucity of evidence. So maybe in the future we can figure this out. Maybe earlier surgery would be even more better, but we don't know yet. So approaches to the cervical spine. So the anterior approach or the posterior approach based on the injured segment, based on the anatomy of the injury. I think if we go into details, it will be a bit too much. So the approach can be either anterior or posterior. Usually, if an anterior structure is involved, we prefer an anterior approach, or if in some cases we might require an anterior plus a posterior approach. So a 360-degree approach. So based on the injury, we use different instruments to stabilize the spine. And again, as I mentioned, the fusion is achieved by the use of bone grafts. There are multiple approaches to the thoracolumbar spine. Again, depends on which segments are involved, whether anterior or posterior, whether 360-degree fixation is required. And there are multiple fixation techniques for both the cervical and lumbar spine, but there's no real evidence to support one fixation method over the other. Maybe eventually we will have a clear idea about this with emerging research, but there are many techniques: posterior fixation techniques, anterior fixation techniques, circumferential techniques, vertebral body replacement techniques, and vertebral body augmentation techniques. So multiple techniques are available. No clear winners, but maybe we can figure that out with more research. So complications of spinal cord injuries, cardiovascular, respiratory, gastrointestinal, skin, neurological. So the entire body is affected, and this highlights the importance of having a multidisciplinary approach in managing these patients in dedicated spine injury clinics. So in the future, hopefully we can cure this condition. Significant advances in managing caring for patients with spinal cord injury has reduced the mortality rate. Previously, almost 100% mortality has become a condition where the patients can live with the disease. But there is no ultimate cure for spinal cord injury. We cannot get back spinal cord that has been injured. There has been extensive research into this topic, but we still do not have an effective treatment to restore motor or sensory function in an injured spine. There are lots of investigative methods: pharmacological, tissue engineering, cell therapy, cellular regeneration, molecular therapies, physical stimulation, surgical therapies, 3D printing of tissue scaffolds. None of that has come into practice yet. All of them are investigational. Maybe in the future we will be able to manage these conditions more adequately. Yeah, so this concludes my presentation. So I'll hand over to Dr. Zaha, who will be presenting on our case series on spine injury at IGMH.